Okay, let's unpack this. Imagine a single microscopic cell that holds the power to rebuild an entire human system. Not just fix it, but completely replace it, giving someone a new lease on life. Sounds like science fiction, right? Yet this astonishing reality underpins one of modern medicine's most profound achievements, hematopoietic cell transplantation, or HCT.
Absolutely. And this deep dive isn't just about understanding a medical procedure. It's about truly grasping the profound biological principles, the intricate clinical decisions, and the continuous innovation behind what is undeniably one of medicine's most transformative therapies. Today, our mission is to explore every topic and every concept in Chapter 114 of our source material, really master this information so you can understand with the same depth as the elite professionals in this field.
That's our goal. To take a deep dive into HCT, moving beyond just the original bone marrow transplantation idea to cover every facet. We'll look at what it is, where these incredible stem cells come from, how the whole process works, the challenges patients face, and the astonishing range of diseases it can treat. You're about to get a shortcut to being truly well-informed and indeed deeply knowledgeable on this vital and complex subject. Hashtag marvel of the hematopoietic stem cell, HSC. So to kick us off, let's talk about the star of the show, the hematopoietic stem cell, the HSC. What makes this particular cell so incredibly special, so unique, that it forms the very foundation of such a complex and life-altering procedure?
Well, the hematopoietic stem cell, or HSC, it possesses a truly remarkable set of features. These make HCT not just possible, but clinically feasible and profoundly impactful. The profound insight here, what truly sets these cells apart, is their sheer regenerative capacity. I mean, just imagine this. Our source material highlights that the transplantation of even a single isolated stem cell can completely regenerate an entire lymphohematopoietic system in an adult mouse. In humans, we see this incredible power on a larger, more impactful scale. A surprisingly minuscule percentage of a donor's bone marrow volume can sustainably and completely replace the recipient's entire system. It's not just repair, it's a total biological reset. It demonstrates an astonishing capacity for renewal within us.
That's astonishing. When you say entire lymphohematopoietic system, that sounds incredibly comprehensive. What exactly does that encompass? What's being rebuilt here?
It is truly comprehensive, yes. We're not just talking about the obvious circulating blood components, the things we usually think of. This means everything that makes up your blood and immune system. It encompasses all your red cells, which are your body's oxygen carriers. Then you have the granulocytes, a critical part of your innate immune defense, the immediate responders to infection, both B and T lymphocytes, which are the sophisticated components of your adaptive immunity, responsible for targeted and memory responses against pathogens. And of course, your platelets, critical for blood clotting and stopping bleeding. But crucially, it also extends beyond the circulating blood cells. It rebuilds and replaces the fixed macrophage populations throughout the body. These are specialized immune cells that reside in tissues. So this means cells like the Kupffer cells that patrol your liver, the pulmonary alveolar macrophages in your lungs, clearing debris and pathogens, osteoclasts responsible for bone remodeling, and even the Langerhans cells of your skin, vital for local immune surveillance. It's a total system overhaul, a complete reconstruction, all orchestrated by these amazing, powerful cells.
That's truly remarkable, the sheer intelligence of these cells. Not just rebuilding, but knowing where to go. How does that homing ability work? How do these cells find their way to the marrow after just being injected intravenously, randomly?
That homing ability is one of the most fascinating aspects, yes.
Yeah.
It makes intravenous infusion directly feasible and, frankly, profoundly elegant. It's essentially a precise molecular navigation system, a biological GPS, if you will. It's mediated by a critical interaction between a specific chemokine called CXCL12, also known as stromal cell-derived factor 1. This CXCL12 is constantly produced by the marrow stromal cells, the supportive cells that create the perfect environment within the bone marrow. The stem cells themselves have a highly specific antenna on their surface, you could say. It's an alpha-chemokine receptor called CXCR4, so the marrow puts out this chemical beacon, this signal, and the stem cells have the exact receptor to pick it up.
So the marrow puts out a signal, and the stem cells have the antenna to pick it up. It's like they're being called home.
Exactly, they're called home. But the process is even more complex. It involves a precise molecular dance. This homing is also significantly influenced by the interaction of other cell surface molecules. Think of them as like molecular Velcro. There's a group called selectins, specifically E and L-selectin, which are found on the bone marrow endothelial cells, the cells lining the inside of the blood vessels within the marrow. These selectins engage with their corresponding partners, known as integrins, which are found on the surface of the stem cells. This intricate dance of molecular recognition and adhesion, it slows the stem cells down, guides them from the fast-flowing bloodstream, helps them cross the vessel wall, and directs them precisely to their intended destination within the marrow space. Once there, they can engraft and begin their work regenerating the entire system. This inherent ability, along with their cryopreservation capability, the incredible capacity to be frozen and stored for later use without losing their potency, these are what truly make HCT a clinically practical and transformative therapy. They enable procedures that would otherwise be, well, impossible.
That intelligence, that precise homing ability, it truly underpins this entire procedure. Okay. So, with that understanding of the cell itself, the next big question becomes, who are we getting these cells from and where exactly are they collected? Let's break down the different patient-donor relationships and anatomical sources our source material lays out.
Absolutely. The who determines a huge part of the transplant's immunological landscape and the overall dynamics. We primarily categorize hematopoietic cell transplantation by the relationship between the patient and the donor. The first category, and from an immunological perspective, the most straightforward, is syngeneic transplantation. This involves identical twins serving as both the donor and the recipient. While it accounts for only about 1% of all cases, its advantages are incredibly significant. Because the genetic makeup is identical, there is absolutely no risk of graft-versus-host disease, or GVHD.
Right, GVHD, where the donor cells attack the recipient.
Exactly. And unlike autologous transplants, which we'll discuss in a moment, there's no risk of contaminating the stem cells with residual tumor cells from the patient's own body. It's the ideal scenario, immunologically speaking, if available. Then we move to the most common, and certainly the most immunologically complex type, allogeneic transplantation. This is where the donor and recipient are not genetically identical. And this is where the core immunological challenge really comes into play. It introduces a dual risk. First, GVHD, as you said, the transplanted immune cells from the donor reacting against the patient's tissues, perceiving them as foreign. And second, the risk of graft rejection. If the intense immunosuppressive preparative regimen given before the transplant isn't sufficient, the patient's own remaining immune system can reject the transplanted graft. The severity and likelihood of these complications are profoundly influenced by the degree of matching for a specific human leukocyte antigen, or HLA molecules.
So HLA molecules are truly crucial for matching. Can you elaborate on them? What exactly are these molecules and how do they function in this complex context of acceptance or rejection?
You've hit on one of the most critical aspects, absolutely. HLA molecules are specialized cell surface proteins. They're encoded by genes within what's called the major histocompatibility complex. Their fundamental role is like the body's ID cards. They bind fragments of antigenic proteins, these can come from infections, or from the body's own proteins, including sometimes tumor proteins, and then they present these fragments to T cells. This presentation is precisely how T cells recognize and respond to foreign invaders or abnormal cells. Now, when a donor and recipient are not HLA matched, the T cells from one individual will react very strongly against the mismatched HLA molecules, which we call major antigens, of the second individual. It's a powerful immune reaction. Even if they are perfectly HLA matched for the major antigens, donor T cells can still react to differing minor antigens presented by the recipient's HLA molecules. These reactions tend to be less vigorous, but it's a subtle, important distinction. The genes of major relevance in transplantation are HLA-A measures B, C, and HOD. These genes are closely linked and inherited together as what we call haplotypes, meaning they are usually passed down from parent to child as a block, with only rare genetic crossovers. This is why the odds that any one full sibling will be an HLA match for a patient are exactly 1 in 4. Mathematically, the probability of having an HLA identical sibling is calculated as 1 minus 0.75 raised to the power of n, where n is the number of siblings you have. Now, even with what we call a perfect HLA match between siblings, there's still a small but real 1–3% risk of graft rejection, and about a 15% risk of severe, potentially life-threatening acute GVHD. The incidence of those graft rejection and GVHD increases progressively as the number of mismatched antigens from family member donors increases. While survival might not be markedly altered with just a one antigen mismatch, it is definitely reduced with 2 or 3 antigen mismatches. So compatibility is really key. However, and this is a significant breakthrough, newer approaches to GVHD prophylaxis, like the innovative use of post-transplant high-dose cyclophosphamide. These have made transplantation possible even between donor and recipient pairs who share only one HLA haplotype, a so-called haploidentical match. This has dramatically expanded the pool of potential family donors.
That's a huge advancement, making more family members potential donors. Wow. But what about unrelated donors? How do we find a match when there's no suitable family member? That sounds like searching for a needle in a haystack.
It is indeed like searching for a needle in a vast genetic haystack, yes. But that's where large global registries come into play. The genes encoding HLA antigens are highly polymorphic, meaning there's enormous natural variation in the human population. The odds of any two unrelated individuals being HLA identical are, well, astronomically low, less than 1 in 10,000. But thanks to incredible global programs like the National Marrow Donor Program, which have recruited over 30 million volunteer donors globally, an HLA match donor can now be found for approximately 60% of patients who initiate a search. It's a real testament to global cooperation. Now, this rate is unfortunately higher among white individuals and lower among minorities and patients of mixed race, highlighting ongoing disparities we still need to address. On average, it takes about 3-4 months to complete a search and schedule an unrelated donor transplant. So there's a time factor too. But what's truly fascinating here, and a critical point for professionals mastering this, is that with continuous improvements in HLA typing techniques and advancements in supportive care, survival following matched unrelated donor transplantation is now essentially the same as that achieved with HLA-matched siblings. That was a significant hurdle we've largely overcome. And it's important to understand, too, that allogeneic HCT can even be performed across ABO blood barriers. This is typically a major consideration in routine blood transfusions, but less so here. This is done by removing isoagglutinins, those are antibodies that react against ABO antigens, and/or incompatible red blood cells from the donor graft itself before infusion. However, even with these careful manipulations, there's still some risk of hemolysis, the destruction of red blood cells depending on the specific direction of the mismatch, and other immune factors. It's another layer of complexity clinicians must manage. Okay, the third primary category is autologous transplantation. This is where the patient is their own donor. Their own bone marrow or stem cells are removed and stored, usually after they've received high-dose therapy for their disease, and then later reinfused back into them.
So, with autologous, if there's no GVHD or rejection, why isn't this always the preferred method? It sounds like it avoids so many of the common and severe complications of allogeneic transplants. What's the trade-off?
That's a crucial question, and it really gets to the heart of clinical decision-making in HCT. You're right, autologous transplantation indeed carries no risk of GVHD or graft rejection. Significant advantages, no doubt. But it comes with two primary drawbacks that make it unsuitable for many conditions, especially certain cancers. The most significant is that it completely lacks a graft versus tumor GVT effect.
Ah, the GVT effect.
Exactly. This GVT effect is a powerful immune-mediated anti-cancer benefit. It's a hallmark of allogeneic transplants, where the donor's immune cells actively seek out and destroy any residual cancer cells in the recipient. Autologous transplants simply don't have this living chemotherapy effect, as some call it. The other risk is that the autologous stem cell product itself can inadvertently be contaminated with the patient's own tumor cells during collection. This could potentially lead to a relapse after the transplant. While various purging techniques have been developed to try and remove these tumor cells from the autologous product before reinfusion, no prospective randomized trials have definitively shown that any of these approaches actually decrease relapse rates or improve disease-free or overall survival for the patient. So it's a careful trade-off, with unique benefits and limitations that dictate which type of transplant is most appropriate for a given patient and their specific disease.
That's a powerful breakdown of donor types and their unique considerations, truly highlighting the nuances involved. Okay. But regardless of who the donor is, the stem cells have to come from somewhere specific in the body. Our source material details 3 main anatomical origins for these vital cells. Let's delve into those.
Precisely. Let's look at the where now, because the source of these cells has important implications for the procedure and its outcomes. Historically, the original source of hematopoietic stem cells for transplantation was the bone marrow itself. This is aspirated directly from the posterior and sometimes anterior iliac crest, the large hip bones of the donor under general or spinal anesthesia for comfort. Typically anywhere from 1.5 to 5 times 10 to the 8th nucleated marrow cells per kilogram of the recipient's body weight are collected for an allogeneic transplant. And importantly, several studies have actually found improved survival following both matched sibling and unrelated transplants when higher numbers of bone marrow cells are transplanted. It emphasizes that quantity matters for successful engraftment and long-term outcomes. The second major source, and one that has increasingly gained prominence, is peripheral blood stem cells, or PBSCs. Hematopoietic stem cells naturally circulate in the peripheral blood, but at very low concentrations, far too low for a practical harvest. So to make it feasible to collect enough stem cells for transplantation, their concentration in the blood needs to be significantly increased. This is achieved through a process called mobilization. This can be done by administering myeloid growth factors, most commonly granulocyte colony stimulating factor, or GCSF. This stimulates the marrow to release more stem cells into the bloodstream. Alternatively, it can be done during the recovery phase from intensive chemotherapy, as the marrow sort of rebounds. Donors are typically treated with these growth factors for about 4 or 5 days, after which the stem cells are collected in 1 or 2 4-hour pheresis sessions. This process is a bit like dialysis. Blood is drawn, specific cells are separated out by a machine, and the rest is returned to the donor.
That sounds much less invasive for the donor than a bone marrow harvest. How effective is this mobilization, and what are the benefits for the patient?
It is indeed less invasive for the donor, yes, making it a very popular option now. In the autologous setting, when the patient is their own donor, transplanting more than 2.5 times 10 to the 6 CD34 cells per kilogram, which is generally an achievable number, leads to remarkably rapid and sustained engraftment in virtually all cases. However, for about 5–10% of patients who don't mobilize enough CD34 plus cells with growth factor alone, the addition of plerixafor, which is a CXCR4 antagonist, can be extremely useful. By blocking that CXCR4 receptor we talked about earlier, plerixafor essentially prevents the stem cells from homing back to the marrow or staying put, allowing more of them to escape into the peripheral blood where they can be collected effectively. Now, when compared to using autologous marrow, the use of peripheral blood stem cells results in more rapid hematopoietic recovery. Blood counts rebound faster. While this faster recovery does diminish the overall morbidity rate of transplantation by reducing the period of high vulnerability to infection. Current studies have not shown improved overall survival for autologous transplants using PBSCs versus marrow. So, faster recovery, yes, but not necessarily better long-term survival in the autologous setting. Now, in the allogeneic setting, using growth factor mobilized PBSCs also leads to faster engraftment than with marrow, which is a clear benefit for the patient. However, and this is a critical nuance for professionals to understand this, comes at a cost: a higher incidence of chronic GVHD. This is attributed to the presence of more donor T cells in the peripheral blood product, and T cells are the main mediators of GVHD. Here's where the complexity deepens. For matched sibling donors, the increased chronic GVHD is actually more than balanced by reductions in relapse rates and non-relapse mortality rates. This ultimately leads to improved overall survival. This indicates that the faster engraftment and potentially stronger GVT effect from PBSCs outweigh the increased GVHD risk in this specific context. However, in the setting of matched unrelated donor transplantation, the use of peripheral blood results in more chronic GVHD without a compensatory survival advantage. This is why, in the matched unrelated donor setting, the use of bone marrow is generally favored over peripheral blood. It emphasizes the precise, context-dependent decision-making involved. The third crucial source, and one that represents a remarkable advancement, is umbilical cord blood. This material, traditionally discarded after birth, contains a high concentration of hematopoietic progenitor cells. Cord blood transplantation from family members is particularly useful when there's an immediate urgent need for transplantation that precludes waiting the 9 or so months generally required for a baby to mature enough to donate marrow. While using cord blood results in slower peripheral count recovery compared to marrow, it's associated with a significantly lower incidence of GVHD. This is a key advantage, perhaps because there are naturally fewer T cells in cord blood, or maybe the T cells present are less mature and thus less reactive. Globally, multiple cord blood banks have developed, meticulously storing over 800,000 cryopreserved units from material that would otherwise be discarded. It's turned biological waste into a profound medical resource.
That's an incredible resource, turning what was once medical waste into life-saving treatment. Wow. What are the main advantages of using unrelated cord blood, especially given its potentially slower engraftment and the cell dose limitations you mentioned?
You've highlighted the core challenges and advantages exactly. The primary advantages of unrelated cord blood are its rapid availability units are cryopreserved and ready to go, and its decreased immune reactivity. This unique characteristic allows for the use of partially matched units, which is particularly important for patients who don't have a perfectly matched unrelated adult donor or a matched sibling. It expands access. Historically, a significant limitation has been the cell dose. The risks of graft failure and transplant-related mortality are directly related to the dose of cord blood cells per kilogram of recipient weight. This previously limited single cord blood transplantation primarily to pediatric and smaller adult patients who require fewer cells. This raises an important question. How have we overcome that cell dose limitation for larger patients? Subsequent trials have found that for patients without suitable single cord units, the innovative use of double cord transplants, transplanting two cord blood units, simultaneously significantly diminishes the risk of graft failure and early mortality. What's truly remarkable here is that even though two units are transplanted, only one of the donors ultimately engrafts and provides sustained blood cell production. The other unit likely provides some initial transient boost or support. Connecting all this to the bigger picture for any aspiring professional mastering this field. Given the similar survival rates now seen with cord blood, matched unrelated donors, and haploidentical family member donors, it means a source of allogeneic stem cells can now be found for almost every patient who needs one. That is a truly transformative advancement, opening up HCT to a vast new population.
So, we've explored the amazing stem cells themselves, their incredible biology, and where they come from. Okay, now let's talk about the critical step before the transplant itself, the preparative regimen. This isn't just a simple prep, it's a meticulously designed and incredibly intensive treatment plan. What are its core purposes?
Indeed, the preparative regimen, administered immediately preceding the stem cell infusion, serves a dual and absolutely crucial purpose. Firstly, its primary design is to eradicate the patient's underlying disease. This could be an aggressive malignancy, like leukemia, or it could be an abnormal lymphohematopoietic system causing a severe non-malignant condition. Secondly, in the setting of allogeneic transplantation, it is absolutely essential to adequately immunosuppress the patient. This prevents their immune system from recognizing and rejecting the transplanted stem cells, which are, after all, foreign to their body. The appropriate regimen is highly tailored. It depends heavily on the specific disease being treated, its stage, and the graft source, whether it's autologous, syngeneic, or allogeneic. There is definitely no one-size-fits-all approach in this complex field.
That tailoring sounds like a delicate balance. Can you give us some specific examples of how these regimens are customized for different conditions?
You're absolutely right. It's a fine art rooted in deep scientific understanding. The spectrum is broad. For example, consider a patient with severe combined immunodeficiency, SCID, receiving a transplant from a histocompatible sibling. In this rare instance, virtually no significant preparative treatment is needed. Why? Because there are no problematic host cells to eradicate that would cause disease, and the patient's immune system is already so profoundly incompetent that they won't reject the graft. It's a unique exception that proves the rule, in a way. In contrast, for aplastic anemia, there isn't a large population of abnormal cells to eradicate, like in cancer. Here, the main goal is immunosuppression. So high-dose cyclophosphamide combined with antithymocyte globulin, or ATG, is typically sufficient to immunosuppress the patient enough to accept the marrow graft. For conditions like thalassemia and sickle cell anemia, which involve hyperactive overproducing blood systems, what we call hyperplastic hematopoiesis, high-dose busulfan is frequently added to cyclophosphamide specifically to eradicate that overactive host hematopoiesis, making space for the healthy donor cells. For malignant diseases, which are the most common indication for HCT, a wide variety of regimens have been developed, each carefully designed based on the specific cancer. Most of these include agents that have high activity against the specific tumor at conventional doses, and where the predominant dose-limiting toxicity is myelosuppression, meaning they suppress bone marrow function. These regimens commonly feature powerful combinations of drugs, like busulfan, cyclophosphamide, melphalan, thiotepa, carmustine, and etoposide. Often they're combined with total body irradiation as well. Each agent in combination is selected to maximize tumor kill while making ample space for the new stem cells to engraft. The intensity is considerable, reflecting the severity of the diseases being treated.
That sounds incredibly intense, with significant immediate toxicity risks. Is there a way to achieve the benefits without such high doses, given those challenges?
That's an excellent and profoundly important question, and it led to a major paradigm shift in the field of HCT. Initially, high-dose or myeloablative treatment regimens were the standard. They aimed to completely wipe out the existing marrow. However, a crucial realization emerged. Much of the anti-tumor effect of allogeneic transplantation actually derives not just from the direct chemotherapy, but from an immunologically mediated graft versus tumor GVT response. This led investigators to question if reduced intensity conditioning, or RIC regimens, might be just as effective in fighting cancer while being much more tolerable for patients, especially those who might not withstand the full force of conventional regimens. The evidence for this GVT effect is compelling and has really reshaped our understanding. Studies show that post-transplant relapse rates are lowest in patients who develop even mild, acute, and chronic GVHD. Conversely, they are significantly higher in those who don't develop GVHD, and even higher in recipients of T-cell depleted allogeneic or syngeneic marrow, where that beneficial GVT effect is deliberately minimized or absent. This is like a flashing neon sign for researchers. A powerful proof of principle for the GVT effect is the remarkable observation that complete remissions can be obtained in many patients who have relapsed after transplant, simply by administering viable lymphocytes from the original donor, a procedure known as donor lymphocyte infusions, or DLI. This directly demonstrates the living immune system's role in clearing residual malignancy. It's a fascinating example of harnessing the body's own defense mechanisms. Accordingly, a variety of RIC regimens have been meticulously developed and studied, ranging in intensity, offering a spectrum of options. At one end are the non-malignant regimens. These are designed to be the absolute minimum required to achieve engraftment. For example, fludarabine, plus a very low dose of total body irradiation, maybe 200 centigrade, often just a single treatment. If no transplant were performed, these specific regimens would cause only transient myelosuppression. The patient's own marrow would likely recover on its own. Then there are the reduced intensity regimens, which would cause significant but not necessarily fatal myelosuppression in the absence of transplantation. For example, fludarabine combined with melphalan.
These still pack a punch, but are less aggressive than the full myeloablative protocols. Clinical studies to date overwhelmingly document that engraftment can be readily achieved with these RIC regimens, and crucially, with less direct toxicity to the patient compared to conventional high-dose transplantation. Complete and sustained responses have been documented in many patients, particularly those with more indolent hematologic malignancies, where the immune effect is perhaps more critical than outright tumor eradication by chemo. The trade-off, however, is generally higher relapse rates following reduced intensity conditioning, because the direct tumor-killing effect of the chemo is lower. But this is significantly balanced by lower transplant-related mortality. This balance means that RIC is favored for patients with significant comorbidities, other health issues who might not tolerate the more aggressive high-dose regimens. Conversely, high-dose regimens are still favored in patients considered robust enough to tolerate the full treatment, especially if they have any evidence of measurable disease at the time of transplant, where that direct cytotoxic effect is still highly desired to debulk the tumor.
This dynamic choice is a cornerstone of modern HCT practice. #the procedure and engraftment journey.
Once the patient is prepared through that incredibly precise regimen, the actual stem cell infusion takes place. What does that procedure involve, and what happens in the immediate aftermath as the body begins its long, vulnerable road to recovery?
The procedure itself, the infusion of the cells, is surprisingly straightforward and relatively quick, especially considering the complexity of the preparation and the profound biological changes it initiates. If bone marrow is the source, it's usually collected from the donor's posterior and sometimes anterior iliac crest, those hip bones with the donor under general or spinal anesthesia for comfort. Typically, 10 to 15 milliliters per kilogram of marrow is aspirated, placed in heparinized media to prevent clotting, and carefully filtered to remove any fat or tiny bone spicules. Bone marrow donation is generally safe, with only very rare complications reported for the donor. If peripheral blood stem cells are being used, they're collected by leukapheresis. This is done after the donor has been treated with hematopoietic growth factors, or in the autologous setting, sometimes after a combination of chemo and growth factors, to mobilize the stem cells into the bloodstream. Once collected, regardless of the source, the stem cells for transplantation are infused into the patient through a large-bore central venous catheter, much like a regular blood transfusion. These infusions are usually well tolerated, though occasionally patients might develop transient fever, a cough, or maybe shortness of breath. These symptoms typically resolve quickly just by slowing down the infusion rate. If the stem cell product has been cryopreserved using dimethyl sulfoxide or DMSO, patients might experience short-lived nausea or vomiting due to the distinctive taste and smell of this cryoprotectant. It's a known minor side effect. It's also worth noting that the graft might undergo manipulation before infusion for specific clinical reasons. Maybe to prevent hemolysis and ABO-incompatible transplants, or to remove donor T cells to prevent GVHD, or an autologous transplantation to attempt to remove any contaminating tumor cells.
So the cells are in. What does the initial recovery look like? Is it immediate, or is there a period where the patient is still very vulnerable, a kind of waiting game?
Oh, there's absolutely a significant vulnerable period, yes. A critical waiting game that we refer to as the nadir phase. After the intensive preparative regimen, the patient's peripheral blood counts reach their lowest point, their nadir, usually several days to a week after the transplant. This is a direct, unavoidable consequence of the intensive conditioning that wiped out their existing marrow. During this time, they have profoundly low counts of all blood cells.
Right, so high risk of infection and bleeding.
Exactly. They're highly susceptible. Then, gradually, cells produced by the transplanted stem cells begin to appear in the peripheral blood. The rate of this crucial recovery, what we call engraftment, depends on several factors. Primarily the source of the stem cells, and whether myeloid growth factors are used after the transplant. If marrow is the source, recovery to a baseline of 100 granulocytes per microliter typically occurs by day 16 on average, and to 500 per microliter by day 22. The use of GCSF-mobilized peripheral blood stem cells speeds this rate of recovery by about 1 week compared to marrow, leading to faster engraftment. However, engraftment following umbilical cord blood transplantation is typically delayed by about 1 week compared to marrow, often due to the lower cell numbers. If a myeloid growth factor is administered after the transplant, it can accelerate recovery by an additional 3 to 5 days. Platelet counts, crucial for clotting, generally recover shortly after the granulocytes do.
That's about the general blood counts. But the immune system, that's a whole different beast, right? How long does it take for the body's defenses to truly rebuild to a functional state to protect the patient from the outside world?
You're spot on. Immune reconstitution is a much more prolonged and nuanced process than just the blood counts recovering. While granulocytes and other components of innate immunity, your body's immediate, non-specific defenses recover relatively rapidly after HCT. Adaptive immunity, which consists of cellular or T-cell immunity and humoral or B-cell immunity, may take a full 1–2 years to fully recover. This extended period leaves patients vulnerable for quite some time. In the first few months after HCT, T-cell recovery is predominantly driven by the survival and peripheral expansion of the infused donor T cells. This initial population primarily consists of CD8 plus T cells, important for directly killing infected or cancer cells, but they have a somewhat limited repertoire of immune responses. After several months, a crucial shift occurs. The de novo generation of donor-derived CD4 plus and CD8 plus T cells from the newly engrafted stem cells becomes the dominant mechanism. This new generation provides a much more diverse T-cell repertoire, essential for long-term, broad-spectrum protection against a wide array of pathogens. B-cell counts, critical for antibody production and memory immunity, typically recover by 6 months after autologous HCT and by 9 months after allogeneic HCT. In general, immune recovery happens more rapidly after autologous HCT compared to allogeneic HCT, and also more quickly after receiving unmodified grafts compared to grafts where T cells have been deliberately depleted either in vivo or ex vivo to reduce GVHD risk. Removing those T cells delays immune reconstitution. For allogeneic transplantation, engraftment can be meticulously documented using techniques like fluorescence in situ hybridization, FEH, of sex chromosomes if the donor and recipient are sex mismatched, or by analyzing specific short tandem repeat polymorphisms after DNA amplification. These molecular methods precisely confirm that the new cells are indeed from the donor, ensuring the engraftment is successful and sustained.
So the stem cells have engrafted and the body is rebuilding. But this intensive process doesn't come without significant challenges. Our source material details a spectrum of complications, both immediate and long-term. Let's start with those early issues, those that appear right after the preparative regimen.
Right. The preparative regimen, while absolutely essential, can cause a wide spectrum of acute toxicities immediately following transplant. These vary in intensity depending on the specific regimen and agents used, but frequently include pronounced nausea, vomiting, and a mild skin erythema or redness. High-dose cyclophosphamide, for instance, can result in hemorrhagic cystitis, painful inflammation of the bladder with bleeding. Thankfully, this can usually be prevented with careful bladder irrigation or by administering the compound Mesna. Most high-dose preparative regimens also lead to oral mucositis, which is painful inflammation and ulceration of the mucous membranes in the mouth. This typically develops 5 to 7 days after transplant and often requires strong narcotic analgesia. Using a patient-controlled analgesic pump often provides the greatest patient satisfaction and results in a lower cumulative dose of narcotic. Keratinocyte growth factor, known as palifermin, can also significantly shorten the duration of mucositis by several days, especially after autologous transplantation. On a more visible note, patients usually start losing their hair about 5–6 days after transplant, and by 1 week, they are typically profoundly pancytopenic.
Meaning their blood counts have hit rock bottom?
Exactly. Very few red cells, white cells, or platelets, leaving them highly vulnerable. One of the more severe early complications occurring in 3–10% of patients depending on the conditioning regimen is sinusoidal obstruction syndrome, SOS, of the liver, sometimes called veno-occlusive disease, or VOD. This syndrome results from direct cytotoxic injury to the hepatic venular and sinusoidal endothelium, the delicate lining of the tiny blood vessels in the liver, leading to a local hypercoagulable state, sort of like tiny clots forming. This chain of events results in a very tough situation. The liver becomes enlarged and painful, tender hepatomegaly. Fluid builds up in the abdomen, ascites, jaundice develops, and general fluid retention. These symptoms can develop any time during the first month after transplant, the peak incidence typically around day 16. Predisposing factors include prior exposure to intensive chemo, any pre-transplant hepatitis, and the use of more intense conditioning regimens. The mortality rate for severe SOS is unfortunately around 30%, often progressing to progressive hepatic failure and culminating in a terminal hepatorenal syndrome.
Thankfully, the targeted treatment of severe SOS with defibrotide, a polydeoxyribonucleotide, has been shown to reduce mortality, offering a critical lifeline for these patients. While most pneumonias developing early after transplant are infectious, a small percentage of patients, a diffuse interstitial pneumonia can develop as a direct result of the high-dose preparative regimen's toxicity to the lungs. Diagnosis usually involves bronchoalveolar lavage, which typically shows alveolar hemorrhage, and biopsies characterized by diffuse alveolar damage. High-dose glucocorticoids or anti-TNF therapies are sometimes used for treatment, but rigorous randomized trials definitively proving their utility haven't yet been reported. It's an ongoing area of research. Another early and serious complication is transplant-associated thrombotic microangiopathy, or TMA, seen in 5–10% of patients, typically appearing about 1 month after transplant. This syndrome is characterized by the presence of schistocytes, fragmented red blood cells, a telltale sign of microvascular damage on a blood smear, elevated LDH, low platelets, and acute kidney injury.
It's the result of widespread endothelial injury in small blood vessels and uncontrolled complement activation. Since calcineurin inhibitors, common immunosuppressants used post-transplant, are thought to contribute, changing immunosuppressive regimens is sometimes effective. Patients have also shown response to eculizumab, which blocks part of the complement system.
Those early complications are indeed daunting, truly a critical period. But what about the long-term impact? Are there effects from the treatment that show up much later, months or even years down the line, that clinicians have to manage?
Yes, unfortunately, there are significant late toxicities as well, appearing more than 3 months after HCT, sometimes years later. In terms of chronic pulmonary disease, there are 2 main categories. First, cryptogenic organizing pneumonia, a restrictive lung disease. Patients present with a dry cough, shortness of breath, and chest imaging typically shows a diffuse, fluffy infiltrate. A biopsy reveals granulation tissue within alveolar spaces and small airways, no infection. The good news, and a relief for patients, is that this disease responds remarkably well to corticosteroids and is entirely reversible. The second, and often more challenging, is bronchiolitis obliterans. This is an obstructive lung disease. It presents with a persistent cough, progressive difficulty breathing, and radiological evidence of air trapping in the lungs. Pathologically, it shows collagen and granulation tissue in and around bronchial structures, eventually leading to the irreversible obliteration of small airways. This disease is usually associated with chronic GVHD, and while it may respond to increasing immunosuppression, complete reversal is uncommon, making it a very serious long-term issue.
Other late complications directly linked to the preparative regimen include decreased growth velocity in children transplanted at a young age and delayed development of secondary sex characteristics. These can thankfully be partly mitigated with appropriate hormone replacement therapy. About 50% of women will develop ovarian failure, which should be treated. Though it's important to counsel patients that pregnancy is still possible after transplantation, a point of great hope for some. Thyroid dysfunction is sometimes seen, but usually well compensated with medication. Cataracts, a clouding of the eye's lens, develop in 10–20% of patients. They're most common in those treated with total body irradiation and those who receive prolonged glucocorticoid therapy for GVHD. Finally, aseptic necrosis of the femoral head bone tissue death due to lack of blood supply in the hip is seen in 10% of patients and is particularly frequent after chronic glucocorticoid therapy. This can lead to pain and joint dysfunction.
It's important to note that both acute and late camera radiotoxicities, except those specifically caused by glucocorticoids and other agents used to treat GVHD, are less frequent in recipients of reduced-intensity conditioning regimens compared to high-dose regimens. That highlights a key advantage of the RAC approach.
Beyond the direct toxicities of the treatment, what happens if the transplanted cells just don't take, or after a period, stop working? That's what we call graft failure, correct?
Precisely. That's termed graft failure. And while complete and sustained engraftment is usually achieved, occasionally marrow function either doesn't return at all after the nadir, or returns briefly only to be lost later. In autologous transplantation, where the patient is their own donor, graft failure can be due to several reasons. Inadequate numbers of stem cells initially transplanted, perhaps if mobilization was poor, or damage to the cells during ex vivo treatment or cryopreservation and storage, or the patient's exposure to additional myelotoxic agents after transplant that can harm the newly engrafted cells. Infections with cytomegalovirus (CMV) or human herpes virus type 6 have also been associated with this loss of marrow function, indicating the complex interplay of factors. In allogeneic transplantation, graft failure can also be due to immunologic rejection of the graft by any residual immunocompetent host cells. This rejection is generally thought to be primarily T-cell mediated. What's truly fascinating here, and a critical piece of modern practice, is that the presence of donor-specific HLA antibodies in the patient prior to HCT is strongly associated with poor engraftment.
This crucial insight has led to the widespread recommendation for meticulously screening recipients for these donor-directed anti-HLA antibodies before the transplant. This allows for risk stratification and, if necessary, desensitization therapies. Immunologically based graft rejection is more common when less immunosuppressive preparative regimens are used, in recipients of T-cell depleted stem cell products, and in patients receiving grafts from HLA mismatched donors or cord blood, all scenarios where the immune disparity or insufficient immunosuppression might be greater, leading to a higher risk of the host fighting off the graft. When graft failure occurs, the initial steps for treatment involve removing all potentially myelotoxic agents from the patient's regimen and maybe attempting a short trial of a myeloid growth factor to stimulate any potential remaining marrow activity. For allogeneic transplant recipients with graft failure, the persistence of lymphocytes of host origin in their blood is a strong indicator of immunologic rejection. In such cases, simply reinfusing donor stem cells is usually unsuccessful unless it's preceded by a second, more intensive immunosuppressive preparative regimen to again suppress the host immune system. The challenge with retreatment is that standard high-dose preparative regimens are tolerated poorly if administered within 100 days of a first transplant due to cumulative toxicities. However, the development of reduced-intensity conditioning regimens has shown effectiveness in some cases, offering a less toxic path for re-engraftment and a chance for these patients.
Now let's turn to perhaps one of the most unique and significant complications of allogeneic transplantation, graft-versus-host disease, or GVHD. It truly sounds like the transplanted body turning on itself. How does this critical battle unfold?
That's a very apt description. GVHD is a major immune complication. Essentially, the donor's new immune cells reacting against the recipient's tissues, perceiving them as foreign despite all the matching efforts. It's a paradox of this powerful therapy. There are two main forms, acute and chronic. Acute GVHD typically occurs within the first 3 months after an allogeneic transplant, with a peak onset around 4 weeks. Clinically, it's characterized by a distinct erythematous maculopapular rash, a red, raised, bumpy rash, often starting on palms and soles and progressing. Also by persistent anorexia or diarrhea, or both, which can be quite severe, and by liver disease, indicated by increased serum levels of bilirubin and liver enzymes like ALT, AST, and alkaline phosphatase. Because many other conditions can mimic acute GVHD, a definitive diagnosis usually requires a biopsy of the affected organs, skin, liver, or intestine, to confirm the characteristic tissue damage. Pathologically, in all these organs, we see endothelial damage and lymphocytic infiltrates. Specifically in the skin, the epidermis and hair follicles are damaged. In the liver, the small bile ducts show segmental disruption. And in the intestines, destruction of the crypts and mucosal ulceration may be noted. The severity of acute GVHD is meticulously categorized using a commonly used rating system. This helps guide treatment and prognosis. This system stages involvement of the skin, liver, based on bilirubin levels, and gut, based on diarrhea volume, to assign an overall clinical grade from I to 5. Grade 1 is considered to be of little clinical significance and typically doesn't require aggressive therapy. In stark contrast, grades 2 to 4 GVHD are associated with significant symptoms, a poor probability of survival, and demand aggressive therapeutic intervention. The incidence of acute GVHD is higher in recipients of stem cells from mismatched or unrelated donors, in older patients, and in patients who are unable to receive the full doses of drugs intended to prevent the disease.
So, given its potential severity, how is GVHD prevented or managed? Is it always a given, or can we truly influence its occurrence?
That's the ongoing challenge, and a major focus of research, absolutely. Currently, the standard approach to GVHD prevention involves administering a calcineurin inhibitor, like cyclosporine or tacrolimus, combined with an antimetabolite, like methotrexate or mycophenolate mofetil, starting right after transplantation. These drugs work by dampening the immune response. The addition of anti-T-cell immune globulin, or ATG, may further reduce the incidence of GVHD by depleting T cells, but studies haven't conclusively shown it improves overall survival. So there's a balance of benefits and risks there. Other promising approaches are being actively tested in phase 3 studies. These include adding sirolimus to the standard 2-drug regimen, selectively removing subsets or all T cells from the stem cell inoculum before infusion, trying to remove the attacking cells, and using cyclophosphamide administered several days after transplant, which helps deplete activated alloreactive T cells that might be primed to attack. Despite all these meticulous prophylactic measures, significant acute GVHD will still develop in about 30% of recipients of stem cells from matched siblings, highlighting its complex and challenging nature. Factors consistently associated with a greater risk of acute GVHD include HLA mismatching, increased patient and donor age, the use of more intense preparative regimens, and surprisingly, the use of multiparous women as donors.
Multiparous women, women who've had multiple pregnancies.
Yes, exactly. Presumably because they have more alloreactivity due to carrying genetically disparate fetuses during pregnancies, which can sort of prime their immune system. If we connect this to the bigger picture, recent groundbreaking research has highlighted that disruption of the intestinal microbiota, the community of microbes in your gut leading to a loss of diversity and overgrowth by a single type of bacteria, is strongly associated with a higher risk of GVHD and transplant-associated mortality. This points to entirely new avenues for prevention, perhaps modulating the gut microbiome. Furthermore, specific biomarkers like ST2, REG32, and TNFR1 have been identified that can help predict the severity of acute GVHD, allowing for earlier intervention, perhaps. When the disease does develop, it's usually treated initially with prednisone, a powerful corticosteroid, typically at a daily dose of 1 to 2 milligeochedrons. Patients whose acute GVHD doesn't respond to prednisone, or those with steroid-refractory disease, sometimes respond to ruxolitinib, an oral JAK2 inhibitor. That's been a significant addition to our therapeutic arsenal.
Moving to the second form, chronic GVHD occurs most commonly between 3 months and 2 years after an allogeneic transplant, developing in 20–50% of recipients. It's more common in older patients when peripheral blood rather than bone marrow is used as the stem cell source, in recipients of mismatched or unrelated stem cells, and in those who experienced a preceding episode of acute GVHD. The clinical presentation of chronic GVHD remarkably resembles an autoimmune disorder, where the body's immune system attacks its own tissues. Patients can present with a malar rash, butterfly-shaped rash on the face, Sika syndrome, painful dry eyes and mouth, arthritis, obliterative bronchiolitis, that's a serious lung condition, and bile duct degeneration leading to cholestasis, a liver problem. It can affect almost any organ system, making it incredibly debilitating. Treatment for chronic GVHD varies by severity and site. Mild cases can sometimes be managed using local therapies, like topical glucocorticoids for skin or cyclosporine eye drops for dry eyes. More severe disease, however, requires systemic therapy, usually with prednisone alone or combined with cyclosporine.
Ibrutinib, a Bruton's tyrosine kinase inhibitor, is sometimes effective in patients whose disease doesn't respond to initial therapy, offering another option for refractory cases. Mortality rates from chronic GVHD average around 15%, but can range widely from 5% to 50% depending on severity and organ involvement. In most patients, chronic GVHD eventually resolves, but it may require 1 to 3 years of continuous immunosuppressive treatment before these agents can be safely withdrawn without the disease recurring. A crucial implication here for patient management is that because patients with chronic GVHD are significantly susceptible to infection due to their prolonged immunosuppression, they should receive prophylactic trimethoprim sulfamethoxazole, and all suspected infections must be investigated and treated aggressively. This vigilance is paramount for patient safety. It's also worth noting that while onset before or after 3 months is often used to distinguish between acute and chronic GVHD, occasional patients develop signs of acute GVHD after 3 months, known as late-onset acute GVHD. Others may exhibit signs of chronic GVHD earlier or with features of both, creating complex overlap syndromes.
Our source material indicates there are currently no definitive data suggesting these patients should be treated differently than those with classic acute or chronic GVHD, but it highlights the continuum of this immune complication. Finally, about 3–5% of patients will develop an autoimmune disorder following allogeneic HCT, most commonly autoimmune hemolytic anemia or idiopathic thrombocytopenic purpura. Unrelated donor source and chronic GVHD are risk factors, but these disorders have also been reported in patients with no obvious GVHD. Treatment is typically with prednisone, cyclosporine, or rituximab.
Okay, the immune system is undergoing this massive change, a complete overhaul, and that leaves patients incredibly vulnerable, especially in the early phases. So how do medical teams protect them from infections, particularly when their new immune system is still developing and adjusting?
This is a critical area of patient management, absolutely. It demands unique and highly proactive approaches. Post-transplant patients, particularly allogeneic recipients, are navigating a period of profound immune suppression and vulnerability. In the very early phase, immediately after transplant, patients are profoundly neutropenic due to the preparative regimen. Their counts of infection-fighting white blood cells, neutrophils, are extremely low, almost non-existent. Because the risk of bacterial infection is so great during this period, most centers place patients on broad-spectrum antibiotics once their granulocyte count falls below 500 per microliter, basically as a preventative shield. Prophylaxis against fungal infections is also vital and has been meticulously shown to reduce rates of serious infection and significantly improves overall survival. Fluconazole is often used for patients at standard risk, while prophylaxis with mold-active agents like voriconazole or posaconazole should be considered for patients at higher risk, like those with a prior fungal infection. Additionally, patients who are seropositive for herpes simplex virus should receive a cyclover prophylaxis, as reactivation is common and painful. Okay, let's unpack this a bit more. Despite these robust prophylactic measures, most patients will still develop a fever and some signs of infection after transplant. The management of patients who become febrile despite bacterial and fungal prophylaxis is a particularly difficult clinical challenge. It's rigorously guided by individual patient aspects, their underlying disease, regimen intensity, prior infections, and the specific institution's local epidemiology and experience. It requires constant vigilance and rapid decision-making. Once patients achieve engraftment, the incidence of bacterial infection diminishes, but they remain at significant risk, especially allogeneic recipients. During the period from engraftment until about 3 months post-transplant, the most common causes of infection shift somewhat. We see more gram-positive bacteria, fungi, particularly Aspergillus, and various viruses, including the notorious cytomegalovirus, or CMV.
Ah, CMV. I've heard that's a big one post-transplant.
It used to be a huge problem, yes. CMV disease, which in the past was frequently seen and often fatal, can now be largely prevented. In seronegative patients transplanted from seronegative donors, prevention involves using either seronegative blood products or products where the white blood cells have been rigorously removed, as white cells carry the virus. In seropositive patients, or those transplanted from seropositive donors, either prophylaxis or preemptive therapy is used. Lidermofir, administered over the first 3 months after transplant, has proven highly effective as prophylaxis. An alternative and widely used approach is preemptive therapy. Meticulously monitoring the patient's blood after transplant, using PCR assays for viral DNA, and then treating reactivation preemptively with ganciclovir before clinical disease develops, effectively nipping it in the bud. Foscarnet is an effective alternative for some patients who develop CMV issues despite ganciclovir or who can't tolerate it, though it can cause severe electrolyte wasting, requiring careful monitoring. Pneumocystis jirovecii pneumonia, which once occurred in 5–10% of patients and could be fatal, can now be largely prevented by treating patients with oral trimethoprim sulfamethoxazole for a week before transplant and resuming it once they engraft. A simple intervention with a huge impact. Emerging respiratory viruses, RSV, parainfluenza, influenza, metapneumovirus, can be life-threatening or fatal in the post-transplant patient. Protecting patients from infected visitors and staff by rigorously avoiding such contacts is absolutely critical. A simple but vital measure. Neuraminidase inhibitors work for flu, and inhaled ribavirin is sometimes used for severe RSV. Beyond 3 months after transplant, if the patient is doing well, the risk of infection generally diminishes considerably, unless chronic GVHD develops and requires continuous long-term immunosuppression. In that scenario, the vulnerability persists. Most transplant centers meticulously recommend continuing trimethoprim sulfamethoxazole prophylaxis as long as patients are receiving any immunosuppressive drugs. They also recommend careful monitoring for late CMV reactivation, as the virus can linger. In addition, many centers recommend prophylaxis against varicella-zoster virus, using a cyclover for 1 year after transplant to prevent shingles. Finally, a crucial part of long-term infection management is a meticulous revaccination schedule. Patients need to be revaccinated against tetanus, diphtheria, Haemophilus influenza, polio, and pneumococcal pneumonia starting at 12 months after transplant, and then against measles, mumps, rubella, MMR, varicella-zoster virus, and possibly pertussis at 24 months. This ensures their newly rebuilt immune system has robust defenses, allowing them to truly regain a more normal life.
We've covered the science, the intricate procedure, and the significant challenges of HCT. Now, let's explore the incredible impact of this therapy on patients' lives. The wide array of diseases it treats, both non-malignant and malignant. Our source provides some compelling insights into success rates and key considerations for each, really showing the power of this medical innovation.
The application of HCT is indeed broad and profoundly transformative. For non-malignant diseases, the evidence-based indications are guided not only by disease factors, but also by a complex interplay of patient comorbidities, socioeconomic issues, caregiver and donor availability, and critically, patient preference. It's a holistic decision, really. First, in immunodeficiency disorders, HCT can cure patients by completely replacing their abnormal stem cells with healthy ones from a normal donor. This includes severe conditions like severe combined immunodeficiency, SCID often called bubble boy disease, Wiskott-Aldrich syndrome, and Chiari-Higashi syndrome. The most extensive experience is with SCID, where cure rates of a remarkable 90% can be expected with HLA-identical donors. And importantly, even success rates of 50–70% have been reported using haplotype mismatched parents as donors, expanding the reach of this life-saving therapy for these very vulnerable children. For aplastic anemia, where the bone marrow stops producing enough blood cells, transplantation from matched siblings, following a carefully chosen regimen of high-dose cyclophosphamide and ATG, can cure up to 90% of patients younger than 40 with severe disease.
90% cure rate. That's incredible.
It is incredibly high, yes. However, results in older patients and those receiving marrow from mismatched family members or unrelated donors are less favorable. Therefore, a trial of immunosuppressive therapy is generally recommended first for such patients before considering transplantation, as it's a less aggressive alternative. HCT is effective in all forms of aplastic anemia, including those associated with PNH and Fanconi's anemia. For Fanconi's anemia specifically, patients are abnormally sensitive to alkylating agents, so less intensive preparative regimens are meticulously employed to minimize harm. In hemoglobinopathies, severe genetic blood disorders affecting hemoglobin, HCT offers truly curative potential. For thalassemia major, marrow transplantation from an HLA-identical sibling after a regimen of busulfan and cyclophosphamide can cure 80–90% of patients. The best outcomes are seen when patients are transplanted before they develop significant complications like liver enlargement or fibrosis, and if they've had adequate iron chelation therapy. Among such carefully selected patients, the probabilities of 5-year survival and disease-free survival are remarkably high, 95% and 90% respectively. It's vital to recognize that while aggressive chelation therapy can prolong survival, transplantation remains the only curative treatment for thalassemia. For sickle cell anemia, transplantation is also potentially curative. 2-year survival and disease-free survival rates of 95% and 85% respectively have been reported following matched sibling or cord blood transplantation. While decisions about patient selection and timing remain difficult due to the chronic nature of the disease, transplantation is increasingly considered for children and young adults who have already suffered severe complications like stroke, recurrent pain crises, lung disease, or kidney problems. It offers a chance for a life free from the constant burden of the disease. Beyond these, HCT has theoretical and proven applications in a fascinating array of other non-malignant diseases. Theoretically, it should be able to cure any disease resulting from an inborn error of the lymphohematopoietic system. It has been successfully used to treat congenital disorders of white blood cells, like Cosman's syndrome, chronic granuloma disease, and leukocyte adhesion deficiency, restoring a functional immune system. Congenital anemias like Black-Stand diamond anemia can also be cured. Since the penetrance of some congenital marrow failure states is variable, meaning some family members might carry the gene but not show symptoms, careful screening of potential family donors is absolutely crucial to ensure they aren't affected themselves. Infantile malignant osteopetrosis, that rare inherited disorder where bone becomes too dense, can also be cured by transplantation because osteoclasts, the bone-resorbing cells, derive from the marrow. HCT has also been employed to treat a number of storage diseases caused by enzymatic deficiencies, like Gaucher's, Hurler's, Hunter's, and metachromatic leukodystrophy. While transplantation for these hasn't been uniformly successful, the key seems to be treatment early in the disease course, before irreversible damage to organs outside the marrow has occurred. Early intervention increases the chance for success. Finally, in a truly exciting expansion, transplantation is even being explored for severe acquired autoimmune disorders. These trials are based on studies showing transplantation can reverse autoimmune disorders in animal models and on observations that occasional patients with coexisting autoimmune issues and blood cancers were cured of both with a transplant.
Cured of both. That's amazing.
It provided a powerful rationale. And in a remarkable breakthrough, a recent prospective randomized trial found that patients with severe scleroderma showed improved event-free and overall survival after myeloablative autologous stem cell transplantation. This is truly pushing the boundaries of what HCT can achieve.
It's amazing how many non-malignant conditions can be cured or dramatically improved, but for many, the association with HCT is primarily for cancer. How effective is it against different types of malignancies, and what are the key factors determining success?
You're right. Malignancy is a major indication, and HCT offers significant curative potential in many cancers, particularly hematologic ones.
Let's delve into some specific examples, highlighting the nuances professionals must master, drawing from our source material. For acute myeloid leukemia, AML, and aggressive blood cancer, allogeneic HCT offers a vital pathway to cure for patients who don't achieve a complete response after initial induction chemo. It is, in fact, the only form of therapy that can cure such patients. That's why HLA typing should be determined soon after diagnosis for all possible transplant candidates. Cure rates improve significantly to 30–35% when patients are transplanted in a second remission or during their first relapse. The best results for allogeneic HCT and AML are achieved during first remission, with disease-free survival rates averaging 55–60%. What's crucial to understand from meta-analyses is a clear survival advantage with match-related donor transplantation compared to chemo for adult AML patients under 60. Greatest for those with unfavorable risk AML.
While HCT can be done in patients up to age 75 and maybe beyond, prospective trials rigorously comparing HCT with chemo are still lacking for older patients. The role of autologous HCT in AML is less well-defined, relapse rates are higher, cure rates somewhat less than allogeneic, mainly due to the lack of that crucial GVT effect. Similar patterns are seen in acute lymphocytic leukemia, ALL. Adults not in complete response after induction chemo can be cured in 15–20% of cases with immediate allogeneic HCT. Cure rates improve to 30–50% in second remission, making transplant a recommended option for adults with persistent disease or who relapse. Transplantation in first remission results in cure rates of about 55%. It appears to offer a survival advantage over chemo for patients with high-risk disease, defined by molecular profiling. There's ongoing debate among professionals about whether adults with standard risk disease should be transplanted in first remission or if it should be reserved until relapse, weighing benefit versus toxicity. Autologous HCT for all has a higher relapse rate but somewhat lower non-relapse mortality compared to allogeneic. No obvious role in first remission.
For second remission patients, most experts recommend allogeneic stem cells if a donor is available, emphasizing the power of GVT. Moving to chronic leukemia. For chronic myeloid leukemia, CML, now largely managed by targeted therapies, allogeneic HCT is indicated for patients in chronic phase who have failed therapy with 2 or more tyrosine kinase inhibitors. Expected cure rates are around 70%. It's also rigorously recommended for patients who present or progress to accelerated phase or blast crisis, though cure rates are lower than 40% and 15% respectively, reflecting the disease's aggression. For chronic lymphocytic leukemia, CLL, although allogeneic HCT can cure patients, it hasn't been extensively studied due to the chronic nature, older patient age, and availability of multiple effective, less toxic therapies. Where studied, complete remissions were achieved in the majority, with disease-free survival rates around 50% at 3 years, despite advanced disease stage at transplant. So it has potential, even if not widely applied. For myelodysplasia and myeloproliferative disorders, allogeneic transplantation can cure between 20% and 65% of patients with myelodysplasia.
Results are generally better in younger patients than those with less advanced disease. However, patients with early-stage MDS can live for extended periods without intervention, so transplant is generally reserved for patients with an International Prognostic Scoring System, IPSS score, of INT2 or higher, or selected patients with unfavorable cytogenetics, indicating higher risk. For myelofibrosis, whether primary or secondary, 5-year progression-free survival rates over 65% have been reported, offering significant hope. It may require many months for the marrow fibrosis to resolve after transplant, a unique aspect here. In lymphoma, HCT plays a crucial role. For patients with disseminated intermediate or high-grade non-Hodgkin's lymphoma, NHL, not cured by first-line chemo, transplantation in first relapse or second remission can still cure 40–50%.
That's a significant salvage rate.
It is a clear advantage over conventional dose salvage chemo. It's currently unsettled whether patients with high-risk disease benefit from transplant in first remission. That's an area of ongoing trials. Most experts favor autologous over allogeneic HCT for these NHL types due to fewer complications and equivalent survival. While autologous HCT yields high response rates in recurrent disseminated indolent NHL, newer agents make its role somewhat unsettled there. However, reduced intensity conditioning followed by allogeneic HCT results in high rates of complete and enduring responses in patients with recurrent indolent lymphomas, highlighting the power of GVT in these slower-growing cancers. The role in Hodgkin's disease is similar to intermediate and high-grade NHL. With transplant, 5-year disease-free survival is 20–30% in patients who never achieve first remission, with standard chemo, and impressively, up to 70% for those transplanted in second remission, a remarkable improvement. Transplant currently has no defined role in first remission for Hodgkin's. For myeloma, patients whose disease progresses after first-line therapy can sometimes benefit from allogeneic or autologous HCT. Prospective randomized studies have definitively shown that including autologous HCT as part of initial therapy significantly improves both disease-free and overall survival. Further benefit is seen with meticulous use of lenalidomide maintenance therapy following transplant extending remissions. The strategy of using sequential transplants autologous followed by non-myeloablative allogeneic has yielded mixed results so far, needing more research. Finally, in solid tumors, HCT has a more limited but very significant role. Patients with testicular cancer where first-line platinum chemo has failed can still be cured in about 50% of cases with high-dose chemo plus autologous stem cell support. This outcome is notably better than low-dose salvage chemo alone. High-dose chemo with autologous support is also being studied for several other solid tumors, including neuroblastoma and pediatric sarcomas, showing promise in specific high-risk contexts. As in most settings, the best results are obtained in patients with limited disease whose remaining tumor is still sensitive to conventional chemo. Few randomized trials in these diseases have been completed, so data is still emerging, and these are often for specific high-risk or refractory cases.
Even with such powerful and transformative treatments, relapse can unfortunately occur. But the journey doesn't necessarily end there. What options are available? What strategies do professionals employ when a patient experiences a relapse after a transplant?
Relapse after transplantation is, without question, a serious challenge. But you're right, for many patients there are indeed further options and strategies to pursue. For patients who relapse following autologous transplantation, they sometimes respond to further conventional chemotherapy. This can occasionally achieve another remission. More significantly, they may also be candidates for a possible allogeneic transplantation, particularly if the remission achieved after their initial autologous transplant was long. A long remission suggests the disease is still somewhat sensitive to therapy, giving a greater chance of response to a completely new approach, bringing in that powerful donor immune system. For patients who relapse following allogeneic transplantation, several unique options are available because they have that new donor immune system already in place. One prominent and often highly effective approach is treatment with infusions of unirradiated donor lymphocytes, known as donor lymphocyte infusions, or DLI.
DLI, right. Giving them boost of the donor's immune cells.
Exactly. It directly leverages the powerful graft versus tumor effect we discussed earlier. It's essentially giving the patient a booster shot of active cancer-fighting immune cells from their original donor. DLI can result in truly remarkable complete responses in a significant proportion of patients, highlighting the profound power of adaptive immunity. As many as 75% of patients with CML, 40% with MDS, 25% with AML, and 15% with myeloma. However, it's not without risks. Major complications of DLI include transient myelosuppression, as the donor cells can temporarily suppress the patient's remaining marrow, and the potential development of GVHD. That's the key trade-off. These complications depend on the number of donor lymphocytes given and the schedule of infusions. Less GVHD is typically seen when lower doses are administered through fractionated schedules, allowing for a more controlled, gradual immune response. This delicate balance of delivering anti-cancer immunity without excessive toxicity is really a hallmark of managing relapse post-allogeneic HCT. #outtrack.
Wow. We've taken an exhaustive deep dive today, really going from the incredible biology of a single transformative stem cell all the way through the complex interplay of donor types, those meticulous preparative regimens, and the myriad of diseases HCT can treat, both non-malignant and malignant. You've truly gained an understanding that goes far beyond the surface, touching on the profound nuances and critical decisions that professionals in this field grapple with every single day.
Exactly. You now possess a comprehensive framework for understanding hematopoietic cell transplantation, seeing it through the lens of those who practice it, drawing from the depth of Chapter 114. This isn't just about memorizing facts, it's about appreciating the intricate biological mechanisms, the immense clinical challenges, and the incredible human stories behind each of those, 100,000 transplants estimated worldwide in 2020. You've seen how expanding donor availability from siblings to unrelated donors and umbilical cord blood is bringing this life-saving treatment to more patients than ever before. This mastery of the information is what truly sets elite professionals apart, and you've just taken a powerful step toward that level of understanding.
And as we reflect on how far HCT has come from, a nascent experimental procedure to a sophisticated life-saving therapy and the continuous refinements in reduced intensity regimens and managing complications, it leads to a powerful thought for you to mull over. What new frontiers do you imagine we might explore in personalized transplantation? Perhaps therapies so finely tuned that we eliminate GVHD entirely or further expand access until every patient in need, regardless of geography or background, can find their perfectly matched transformative gift. The journey of HCT continues, and its future is, well, it's as exciting as its past has been impactful.